Well, I'm going to be quick because you can see Dr. Katherine Wysham's information here on this slide, but she's a staff physician at the VA Puget Sound, does a lot of work in the VA as well as her work at the University of Washington. She is an expert in the areas you see here: frailty, osteoporosis, accelerated aging, and rheumatoid arthritis, and really a leader, I would say, in frailty and rheumatic disease. So we're glad to have her here today. And as we were saying, you can put things in the chat. I will monitor that, and if there are things
Thank you.
that seem like that would be good to bring up right away, we'll do that. Otherwise, we'll hold questions for the end. So, all
Perfect.
right.
Great. I want to thank you, Kelly, for this invitation and for the group for attending. I'm excited to present my work on premature aging and frailty and osteoporosis in RA. And so the roadmap for today, we'll talk about RA and frailty. We'll give some background there. We'll also define osteoporosis. We'll dip into some of my work, combining, evaluating the intersection of aging and frailty and osteoporosis, and then talk about some applications and future directions. So I know the group is rheumatology kind of broadly, but I would love to define rheumatoid arthritis up front because we're going to be talking about that throughout the duration of this talk. So RA is a chronic inflammatory arthritis with a prevalence of about 1% of the population, and that prevalence increases with age. The average onset of rheumatoid arthritis is 30 to 50 years old, but then there is a secondary peak later in life, 60 to 65. It's more common in females than males. However, it does happen in males, and we at the VA have the benefit of studying male osteoporosis and male rheumatoid arthritis. It's a disease where the immune system targets bone and cartilage. If you undertreat RA, that can lead to deformities and disability. And it is not just a joint disease. There are extra-articular manifestations, including interstitial lung disease, ocular inflammation, skin nodules, neuropathy, and sicca symptoms. And thankfully, with the advent of our newer therapies, we don't commonly see rheumatoid cachexia. The treatment goals of rheumatoid arthritis primarily are to use the lowest effective dose of immunosuppression to achieve low disease activity or remission. But secondarily, we have goals of preventing secondary comorbid conditions. So that includes infections, again, using the lowest effective dose of immunosuppression. You can provide vaccination. Patients are at increased risk for cardiovascular disease, so attempting to minimize systemic inflammation and keeping an eye out for cardiovascular preventive therapies. Osteoporosis, aiming to minimize glucocorticoids, maintaining muscle mass and increasing activity, and then also screening for osteoporosis with bone mineral density screening and treatment. And then overall, just promoting function and preventing disability. Importantly, all of these sequelae are age-related conditions. I'm setting the stage here to kind of support the idea that RA is associated with premature aging. So what is osteoporosis? This is a disease of low bone mass and low quality, which increases the risk for bone fragility and fracture. Seen here is normal bone with normal porosity and connectivity. And then as you go to the right, you see that there is more and more porosity and less connectivity. So the architectural integrity of bone is impacted with osteoporosis. RA is a risk factor for osteoporosis in the FRAX, which is a fracture risk calculator for the general population. It's its own button, a dichotomous button. That's how kind of important it is. Fracture rates are increased in rheumatoid arthritis. People with RA have 1.5 to 2 times the risk of lifetime risk of fracture compared to the general population. And that's a 40% lifetime risk of fracture, so that's high. Risk factors for osteoporosis and RA, there are those that are shared with the general population, which include age, low BMI, steroid use, inflammation, disability, and low physical activity. However, there are RA-specific risk factors, including autoantibodies that can stimulate osteoclast activity. This is ACPA, disease activity and duration, as well as erosive disease. And unfortunately, we have many missed opportunities of screening and treatment. There's not clear guidelines of who to screen, when to screen, how often to screen. And so there's a lot of missed opportunities for fracture prevention. And osteoporosis isn't just, you break a bone, you get better, that's it. You can have, the immediate sequelae of fracture, pain, but you can also have chronic biomechanical changes. So importantly, spinal compression fractures, which often happen in multiple levels, can cause a forward stoop that causes issues with breathing, issues with gaze, and also kind of a forward-leaning posture that makes it people more prone to falling. People who fracture again. Subsequent fractures occur in 50% of people. They result in loss of mobility and independence. People who have a hip fracture, 1 in 5 require a long-term nursing home care. 50% have permanent disability. And importantly, fractures like hip fractures are associated with death. So 1 in 5 veterans die after a hip fracture, which is twice the rate of the general population. So what is frailty? Frailty is an excess vulnerability to stressors with a lack of resilience after a stressful event. Seen here, you can think of this health stressor being maybe a surgery or an infection. People who are robust will fully recover, usually completely and relatively quickly. However, as your frailty status increases, you will have slower and less complete recovery. And those who are severely frail may be unable to recover. There are many ways to measure frailty. The geriatricians have been at this for decades, but there are 2 main conceptual models to think about. One is phenotypic frailty. So this is directly measured frailty, and it's generally comprised of low energy, slow gait, low strength, low physical activity, and unintentional weight loss. And then there's deficit accumulation models, this idea that our body can only handle so many deficits. And often these models quantify morbidities, cognitive decline, functional decline, social vulnerability, poor nutrition, and sensory deficits. For the purposes of this talk, I'm going to talk about 3 different instruments. There are many, many instruments that you can use, but for phenotypic frailty, we'll be using the Fried phenotypic frailty measure. For deficit accumulation model, we'll be using the VA Frailty Index. And then there's a patient-reported frailty metric called the Frail Scale, which is a combination of the 2. Importantly, frailty informs clinical care in different subspecialties. So in cardiology, TAVR allocation, people actually are screened for frailty before they have percutaneous interventions, hepatology, liver transplant allocation, as well as surgery. So this is moving into many fields, and I think it should move into our field of rheumatology to help us deliver the best care for our patients. And I always like to put this up here that people conflate frailty, comorbidity, and disability. These are all interrelated concepts, but they're all distinct. People can be frail but not disabled. People can be disabled but not frail. And comorbidity can definitely contribute to frailty and probably disability. So there's probably another arrow that needs to occur here. But these are distinct concepts. So what do we know about frailty and rheumatoid arthritis? We know there's a higher prevalence and the onset of frailty is earlier than the general population. In a meta-analysis, it was estimated that nearly a third of people with RA in multiple cohorts with a mean age of 63 were frail. This is compared to an estimation in the general population of 10% with a mean age of 70. So this is 3 times the rate at nearly a decade younger. Frailty in RA is associated with poor health outcomes, disability, serious infections, hospitalizations, mortality. And we really don't know the best measure of frailty in rheumatoid arthritis. If we think back to that phenotypic measure, and we'll talk more about this later, but using hand grip strength as an estimate for whole body strength is probably very appropriate in the general population. However, in RA, where people can have deformities or pain that limits their grip strength, it may not be the best measure. And thinking about, although we do not know all the mechanisms that drive frailty in RA, but we can think about what might be driving this. And I think the central driver of frailty in RA is this chronic elevated systemic inflammation. You can think about sarcopenia and disability as well. Maybe an upstream issue that we know that's being elucidated in RA is mitochondrial dysfunction, which can lead to immunosenescence and more inflammation and more sarcopenia. You can also have polypharmacy, and particularly glucocorticoids, which can impact many areas, but also exacerbate sarcopenia and altered muscle function, and also osteoporosis. So there's a lot going on that can contribute to frailty in RA. So kind of putting this all together and talking about why I do what I do. So these are my inspirations for my work. When I was in training and fellowship, I saw that we used a lot of prednisone, and we didn't really get a lot of osteoporosis care and training. And so I had this goal of improving care. Learning more about rheumatoid arthritis, I saw that it really wasn't just this dichotomous yes-no risk factor as it was represented in the FRAX calculator. It's really this heterogeneous disease from mild disease to severe and deforming RA. So I started to think about what about RA impacts bone. And within fellowship, I was able to utilize a cohort where we found that increasing anti-CCP level was associated with lower bone mineral density. Maintaining low disease activity was associated with higher bone mineral density. And then also using another cohort, we found that chronic elevations of disease activity are associated with fractures. And looking at that fracture data, when we looked at the subcomponents of disease activity that were most strongly associated with incident fracture, we found these holistic measures, patient global and provider global, were the most significant subcomponents of disease activity associated with fracture. And that made me think, do we have other holistic measures? What else are people doing in the general population? And leveraging a data set that was put together by Patty Katz, we found that frailty was associated with lower bone mineral density in RA. This was cross-sectionally, and this was most pronounced in males. This has been the fuel kind of to my research. And then there's this really important osteoporosis screening and treatment gap, both in RA and in the general population. Like I'd mentioned, people are underscreened, undertreated. We have fracture incidence that's on the rise. There's conflicting and limited guidance for male osteoporosis. And that we don't really use our fracture risk estimate tools because they're time consuming. We can't really automate many of them because there are missing variables within the electronic health record, one of which is the parental history of hip fracture, which is important for the FRAX. And so bringing this together, I wondered if Frailty could offer a tool to improve osteoporosis care and delivery. So within my career development award, which I'm in the last year now, I had many goals. So first and foremost, to evaluate frailty as a risk factor for bone mineral density loss and fractures, so that we could use these data to, in the future, inform kind of screening and treatment. Identifying the best frailty measure in RA, and I probably should change the word best, like the ideal measures of frailty in RA, or comparing frailty measures in RA to see what we might use in this population. And then turning it on its head to identify pathways that predict frailty in RA so that we can find these targets for intervention with the overall goal of improving frailty and osteoporosis care. Oops. So moving on to my work, I first want to set the stage of the two cohorts that we're going to be talking about. So on the left, there's the VERA registry, which is a national registry, multi-site registry within the VA. It's been in practice, or it's existed for over 20 years. There are more than 3,500 veterans who have participated. People are consented at baseline. They provide a couple tubes of serum that's sent to our central site in Omaha, where we can get biomarkers, DNA, et cetera. These patients consent to have their electronic health record data kind of collated into these data sets. And then we have fixed and consistent disease activity measures over time. We enter those into the medical record in structured forms that they can be pulled out using natural language processing. And then within the VA, we have multitudes of different data sets and really robust data so that we can evaluate outcomes in RA. So that's one group that one cohort that I'll be talking about. And within that cohort, I measured the VA Frailty Index. And then as part of my career development award, I also set up a local cohort. This is called the VA FROST cohort, Frailty and Osteoporosis. We recruited 145 veterans over 2 years. They're seen at baseline year 1 and year 2. And they give us blood. We do physical activity measures, physical performance. We do body composition and DEXA, and lots of questionnaires. And we're able to measure frailty in 3 different ways. We have the VA Frailty Index, we have the FREED, and the FRAIL. So we're able to compare these different methods of measuring frailty. So focusing on the work first that's done in my local cohort here. So this is the only table 1 you're going to see, and then I'll talk about some results. So we have 145 veterans, mean age of 65. The majority are male. They have moderate disease activity, and that's by DAS28 ESR. They have established disease, 14 and a half years of disease duration. Their HAC disability score is 0.7. And a quarter are robust. The majority are pre-frail, 60%, and 15% of the cohort at baseline were frail. Importantly, and something to kind of think about, 23% of these people, most of which were male, had had an osteoporotic fracture before enrollment. So that's something that just sticks with me and is important to think about. And throughout the duration, we've had 6 deaths. So the first project that I'd like to present, and you'll see pictures of my staff who are now actually all in medical school on the bottom. So really wanted to compare these 3 different frailty instruments. And this is a busy slide, but I thought it was very beautiful, this alluvial diagram. When you work with young people, they can put together these beautiful pictures for you. And really what I wanted to show here is that you can be robust in one measure and be frail in another. And, usually there's, some correlation between the levels of frailty, but when you do the kappa values, there's actually very poor agreement between these measures. And then we also put forth this new pragmatic way of measuring frailty by substituting chair sit to stand time for hand grip strength within the Fried phenotypic frailty measure. And we found on the right here, another alluvial diagram, you'll have some people shift between groups, but then when we put these, we compare these 2 metrics with our poor health outcomes, which is a composite of falls, hospitalizations, and death. Using chair sit to stand, there was more precision and accuracy in predicting these poor health outcomes than the hand grip strength, which really supports this idea that hand grip strength may be fraught in this population. We may be overestimating frailty in people who have low hand grip strength. We also found that frailty predicts bone mineral density declines in this cohort, but that when we use the Fried sit to stand, which again is on the top here, we actually found good discrimination between the robust, pre-frail, and frail groups. So there was a significant difference and a significant slope in the frail group at baseline. So more support again that frailty in both measures does a pretty good job of predicting BMD declines. However, the sit to stand measure has a stronger ability to predict that decline. Another kind of passion project that we were able to do within this cohort was to see how many people within this cohort actually had clinical DEXAs done. So we were able to, we consented people to give us access to their medical record. And so we took different guidelines and really went through and said, how many people have had DEXAs done in the clinic, and how many people we're working on how many people are actually treated. But because everyone in our cohort had a research DEXA, we were able to say, like, what is the actual gap here? So we used different guidelines, the National Osteoporosis Foundation guideline, the GOP guidelines, and whether or not they'd had a prior fracture as an indication for screening. And this is kind of a busy slide, but essentially 45% of our cohort was not screened for osteoporosis despite meeting osteoporosis screening criteria. And then of those underscreened, 5% had osteoporosis and 50% had low bone mineral density by research DEXA. So there's a huge screening and treatment gap that we were able to show by using our research DEXA and kind of comparing it to what's going on in the clinical side. And this is consistent with other studies and other cohorts, but no one has been able to kind of show what's actually going on in the bones like we've been able to do. Our group also described this concept of secondary frailty in RA. So this was driven by the idea in the general population. Linda Fried, who is the creator of the Fried frailty metric, described this concept in multiple diseases, one of which that's really easy to conceptualize is heart disease and heart failure. So when someone's having a heart failure exacerbation, they may look very frail. And although in that moment they may be very vulnerable to arrhythmias or other poor health outcomes, that's unlikely representing their true underlying physiologic reserve. So the idea is then you treat the underlying disease that's exacerbated and then measure frailty at another point. And so we were wondering if we could try and evaluate that within our cohort. And when we looked in cross-section for people who had, we compared disease activity to each of the metrics or the subcomponents of frailty, and we found that disease activity was significantly associated with low hand grip strength, and exhaustion, as well as weight loss. So thinking that this idea that when RA disease activity is elevated, these subcomponents of frailty are also going to be elevated, suggesting that we might just need to treat RA and then we can do a better job understanding frailty when the disease is under control. We also looked at our cohort longitudinally, and again, this is before we had full completion of our cohort. So this was 65 veterans. put the DAS28-CRP in a mixed ordinal regression, and found that RA disease activity may contribute to frailty progression. So there's an increased odds of becoming frail for each unit increase of DAS28-CRP. Also thinking about what can we do? Can we improve frailty? We measured the resilience in middle life. It's a not commonly used resilience measure. It was hard for us to find one that was applicable to our age group. What we did find that resilience was protective of frailty, or was associated with decreased odds of frailty, and that's in cross section, so I shouldn't say protective, associated with a decreased odds of frailty. And when we looked at the components of resilience that were associated with lower odds of frailty, coping and adaptability, perseverance, and self-efficacy stood out as things that were of particular interest. And so these are things that we've brought into our future work that we'll talk about at the end. All right, moving on to work done in the VERA cohort. So this is the VERA registry. Again, the table 1 here, you'll see this is a majority of our studies has a very similar composition. 2,900 individuals, mean age is 64. More higher rates of males in this cohort, and that's because of the historical nature of it. So people who were the original people who signed up 20 years ago were World War II and Korean War, and even probably World War I veterans as well. So there's a higher rate of males in this cohort. Moderate disease activity, average of 11 years of our disease duration. And then the frailty breakdown by the VA Frailty Index was nearly a third were robust, a little bit more were pre-frail, and just under a third were frail. Again, looking at prior fracture, 29% of people before they even enrolled in this cohort had had a fracture. I went through and adjudicated all of these incident osteoporotic fractures. So 9% of people had a new fracture, and 44% of people died over this 20-year span. And using these data, we were able to use baseline frailty to see if it predicted incident osteoporotic fracture. And importantly, it did. So the risk at mild frailty was nearly twice the rate of people who were robust. If people were moderately frail at baseline, they had nearly 3 times the rate of incident osteoporotic fracture, whereas people who were severely frail had more than 4.5 times the risk of fracture as those who were robust. And this was after adjusting for important covariates like prior fracture, age and sex, et cetera. And because people conflate disability, and people at the beginning of me writing my grant were like, well, just study the HAC. We just studied the HAC, and it does not predict fracture. So disability does not predict fracture after adjustment for the same covariates. And just looking at the components of the VA Frailty Index, wanting to understand like what was it about the components of frailty that drove this association with incident osteoporotic fracture, we found that things that made sense, failure to thrive, muscular issues, peripheral neuropathy, Parkinson's disease, gait abnormalities, and falls were the top drivers of this relationship. Working with a resident here, we also found that frailty predicts death in RA. So there was a stepwise increased risk of death when we evaluated frailty at baseline. So it's something that might have prognostic value as well. And then moving on to things that predict frailty and death. So we were talking about frailty predicting poor health outcomes. Now evaluating things that predict frailty. I want to talk about this biomarker GDF15, growth differentiation factor 15. So introducing you to this biomarker, it's one of the most upregulated molecules with aging, but it's not very well understood. It's thought to be released in settings of stress, which then result in tissue dormancy, cryoprotection, anorexia, and food aversion. And so you can think about this in the setting of a short-term insult, like an infection, that might be very protective. You have an infection and you downregulate all the energy utilization in your muscle and other tissues to try and support your immune system so that you can fight that infection. However, in the long term, it's likely harmful, right? You're turning down all of these different tissues and different organ systems, which can lead to harm. And so we know that with aging, GDF15 is elevated, and also in rheumatoid arthritis, GDF15 is elevated. And chronic GDF15 elevation is associated with cachexia, frailty, and death in the general population. And then in 2024, there was a publication in the New England Journal showing that there was a druggable target, so an anti-GDF15 antibody, increased weight and decreased cachexia symptoms in people with cancer cachexia. So this made me wonder what was its association with frailty in RA. And we were able to evaluate GDF15. This is in the Vera cohort. It predicts frailty and death in RA in the highest quartile. So the nearly 2.5 times the risk of incident frailty or death compared to the first quartile. And this was after adjustment of important covariates. And we also were able to compare GDF15 with a multitude of other biomarkers and antibodies. So there's a broad swath of things done with the baseline serum within the Vera cohort. And interestingly, we saw that GDF15 just was its own story when we evaluated each of these biomarkers and their relationship with incident frailty and death. So these are individual Cox regression models for each biomarker that have been kind of centered and scaled. We see that GDF15 is off to the right with an increased risk of incident frailty or death. And then just trying to validate this and look at it in a different way, we were able to measure GDF15 at the baseline serum samples in my cohort here, and then using our outcomes of frailty or death as well. And we did see that there was, in the highest tertile, an incident risk, there was a significant association with frailty and death in the Frost cohort. And this is using phenotypic frailty and not the VA frailty index, which is a deficit accumulation model. You'll note that these are hugely wide confidence intervals. We only had 18 outcomes. We just adjusted for age and sex. But this is just to try and support this idea that this might be an important biomarker in aging and frailty in RA. All right, that was the whirlwind of things that I've been up to in the last couple of years. I would love to just move on to talking about what I'm hoping to get up to in the upcoming years. So we've been successful in identifying frailty as a risk factor for bone mineral density loss and fractures. I wouldn't say the best frailty measure, I should change these slides, but we've been able to compare frailty measures and put forth a pragmatic measure, which is the chair sit to stand freed modification, highlighting the importance of frailty in RA. So, and also finding pathways that predict frailty and rheumatoid arthritis. But my goal is really to improve frailty so that in the long term, we can prevent falls and fractures in RA. And I want to set the stage that some people think about frailty as this end stage, disease or end stage state where you can't really recover from it. But even in observing my cohort, we see that frailty is dynamic. Some of these changes, likely many of these changes are actually probably driven by disease activity. We are going to try and figure out how to analyze this. But people who are frail at baseline, you can see that they become robust at year one, and then some dip down to becoming frail. And there's just a lot of movement between these groups. So we have the ability to change this. And so moving on to more kind of background for what we're moving on into next. Veterans in themselves are socially isolated. People with rheumatoid arthritis and chronic illnesses are also socially isolated. And when we try to get people to move and to have more physical activity, we know that group-based interventions increase social connectedness and accountability. And when we do physical activity interventions in the general population, they can improve frailty. And when you combine multiple modalities, such as walking and weight training, you have increased improvements. And our own College of Rheumatology recommends physical activity in RA to improve physical function, quality of life, and decrease disability, but these recommendations are not clear. And there are a couple knowledge gaps here. So again, we talked about the fact that these recommendations are not really specific, so our patients are confused. There are CDC recommendations for physical activity, which are virtually unattainable for most of my patients, which is very discouraging. A lot of my patients have concerns about worsening disease pain or flares, which leads to fear of participating in physical activity. And there's generally a lack of accountability. My veterans are socially isolated, and there's a value disconnect. If I move, it hurts. I don't really see the long-term benefit of moving more. And so with this background, and together with my colleague Brittany Meir, we've designed the FIT-RA study, which is functional improvement through interaction and targeted movement in rheumatoid arthritis. And it's a virtual group-based physical activity intervention to promote healthy aging for veterans with RA. And we aim to test whether FIT-RA improves frailty and healthcare quality of life at 12 weeks in pre-frail and frail veterans with RA. We are currently piloting this. So we run this class in cohorts. Our first cohort just finished the first 6 classes and are in the follow-up phase. And we aim to enroll 20 veterans in this pilot. They need to be pre-frail with at least 2 of the 5 freed components. And they participate in these weekly classes that are 90 minutes per week. They're virtually delivered. The beginning third of the class, people are chatting. There's some structured questions to help people talk about what they've been able to achieve or what they haven't been able to achieve. And people can provide encouragement and support to each other as peers. We then teach exercises, the veterans practice their exercises, and at the end, they set goals for the next week. And rather than trying to get people at like 30 minutes of vigorous exercise that is not achievable for these participants, we're really working on getting them some activity with a goal of 15 minutes per day, maybe 25 minutes per day, with increasing duration of activity over time and celebrating days of rest. So this is the overall schematic. So weeks 1 through 6, people set walk goals in week 1, just talk about physical activity in general and safe places to do it. Week 2, they do stretching. Week 3, leg strength exercises. Week 4, balance. 5 is core strength. Week 6 is arm strength. And then after the 6 weeks, they go into a supported maintenance phase where they can drop into weekly classes, but they're really given a structure to try and integrate this into their daily routine. And then we're also going to be evaluating people. The primary endpoint is at week 12, and then we're going to be evaluating people virtually again at week 24 to see what they've actually been up to in the meantime. We've provided them with these journals where they can reflect. These are actually on the right side. These colorful pieces are actually stickers where they can choose what they want to do. There's kind of a set group of things that we want them to do throughout the week, and they can choose what they want to do each day. And they can just write down and check how many steps they were able to do. And then we give them options. There's seated options, there's standing options, and there's more kind of more difficult options as well for each exercise. And so with FIT-RA, where we introduce physical activity and exercise, we hope to promote behavior change through these group sessions, through journaling and reflection, and through the social engagement, the connection of these veterans, and being witness to the first 4 participants going through this. It's been really wonderful. I know many of these. Some of them are my patients. I wasn't sure how they were going to interact, and they all are kind of in it together. And it's really wonderful to observe them talking to each other and encouraging each other, or helping think about different ways of doing their activities. And through this program, we hope that we can improve frailty by reducing fatigue, increasing activity, improving walk speed, stabilizing weight, and improving strength. So as I mentioned, we're piloting this. We're writing grants to try and get the full trial, working with Louise Toma on that as well, trying to expand beyond just pre-frail and frail veterans. So we're piloting it in the general, kind of all people with RA who want to increase physical activity, and dreaming up a CDMRP trial as well. I'm just looking at the time. Okay, I have a little bit of time. There's also things that I'm trying to do to improve the clinical care delivery of osteoporosis in veterans. So I co-director osteoporosis clinic here. And through that clinic, we have developed a high-risk med dashboard where we can help make sure that people are maintaining their medications. Some of the osteoporosis medications require very structured dosing regimens in order to avoid harm. We were able to show that we maintained care during COVID using that dashboard as well, which was great. We have an osteoporosis education class where our nurse contacts people who have had a consult to our clinic and actually provides them education. Many people come to my clinic thinking they're going to talk about osteoarthritis when we're talking about osteoporosis. So this has really been helpful to empower our veterans to have the knowledge they need to make decisions about their care. And then we're using pharmacy pulls to improve our glucocorticoid-induced osteoporosis care delivery by increasing the screening and treatment of veterans who are at risk And lastly, working with folks, we applied for the Office of Rural Health to get funding for this, but we did not get our funding. But we're creating a virtual fracture liaison service where we can use some of these embedded workflows to then proactively uh, uh, contact and consult on people who have had a fracture who live in rural sites. So here in Seattle, we're the hub for Alaska, all of Washington, Idaho. And so if we can find veterans through their electronic health record codes who've had especially a hip fracture and get them integrated into our care and get them on treatment, that could be life-saving for them if they are able to prevent another fracture. And this is in partnership with your GREC and other investigators in Iowa and Utah. So at the end of this talk, I just want to kind of leave you with some ideas of how we can incorporate frailty into clinical care. And I think it's also important to think about this in the context that CMS is actually mandating frailty measurements in the hospital. And there's a big push for multiple healthcare systems to move into this age-friendly healthcare delivery. So here are some ways that I think that we could kind of integrate it in rheumatology. So measuring or screening for frailty in our clinic using the Fried phenotype or the Frail scale, which is very quick and easy. If someone is robust, you just keep on going through their usual care pathway. But if someone is pre-frail or frail or their frailty metrics are declining, these longitudinal metrics are important. You can then provide, different. You can think about them differently. So the rheumatology provider could think about secondary frailty, like are we missing something with disease activity? Have they been on prednisone for too long? Are they getting myopathy? They could be referred to physical therapy for gait balance and falls and strengthening. Perhaps they need a nutrition referral. They're having unintentional weight loss. Pharmacist review could review for polypharmacy and any of the medication that meets the Beers criteria that are at risk for people who are aging. And then also referrals if there's comorbidities that are exacerbated that might be informing their frailty metrics as well. I think even more powerful and things that are already happening here in the VA is using frailty indices that are embedded within the electronic health record. The VA Frailty Index is already available in the geriatrics dashboards, and we're working to kind of pull it through and put it in some of our rheumatology dashboards as well. Importantly, the VA Frailty Index, that same kind of concept is being moved over into EPIC as well. So Ariella Orkabi, who is the queen of the VA Frailty Index, has been working on it diligently within the VA, but also working over in Harvard to work and get it into their Brigham system on the EPIC side. So if you have this kind of automatically pulled up, you can have trends of frailty in your patients. And again, robust people can keep on keeping on. But those who have frailty measured or have declines in their frailty metrics, using these deficits, you can actually, frailty indices, you can actually identify a specific deficit, which can then lead to specific management or referrals. So for example, if someone is noted to have falls within their frailty index, you can refer them to physical therapy, get a bone density test, and get them treated for osteoporosis if they meet treatment indication. And I think it can also inform clinical decision making. If someone is frail, that might inform our treatment options within rheumatology, or even inform kind of, I don't want to say goals of care discussion because that sounds very end of life, but really like facilitate conversations about what matters most to these patients. I'm seeing that your frailty status is, increasing. You're becoming more frail. What are your goals here? Do you want me to use medications that are going to help you just be more comfortable, but maybe have different risks, et cetera? And it can also provide referrals for like prehabilitation if they're going to undergo different surgeries. So in summary, RA is associated with premature aging, and frailty is a holistic measure that can identify risk for poor health outcomes. I think it can inform our treatment approach, and importantly, it can be modified. And in my ongoing work, I'm hoping to continue observational discoveries within my CDA cohorts, hoping to get funding for the FIT RA trial, and continuing to improve osteoporosis care delivery through our multiple QI initiatives. And with that, I'd like to thank my mentors and collaborators and my research team, and my funders, and my kids for just being, wild and crazy and keeping me on my toes. I do have a peer teaching evaluation. As many of you know, it's important for academic promotion. So I'll send the link if you want to snap a QR shot, but I also have a link that I can put in the chat as well. I'd appreciate that. And that helps me also improve my talks. So thank you.
Thank you for that. That was wonderful. I have a question. I'm gonna see if anybody else would like to start. Yes, clapping, lots of clapping. That was a great overview of your work. I really appreciated it. And anybody
Thank
want
you.
to start the questions? I'll start while other people are thinking. So, and you talked about this a little bit at the end, but the whole just the different frailty indices, but just even the broad like deficit accumulation, phenotypic frailty. There are obviously trade-offs of what's easy to collect and then what may be better. I mean, in terms of clinical application, what are you like? What are your thoughts about that? Like, should there be a move towards collecting something that's beyond like the VA frailty index and then moving that out of the VA? It's obviously easy because you have the data there, but there's some
Yeah.
limitations. But it sounds like you've identified some ways that those data can be sort of operationalized into treatment pathways. But they've always seemed like they're really different to me.
Yep.
Like those, and so, but yeah, we call them both frailty. So I just wonder if you have other things you'd like to say and help us
Yeah.
understand about those different definitions and what maybe the implications are either for clinical practice or research. What are the considerations for choosing measures and where should
Yeah.
we be going as a field?
I think first and foremost, most of these are going to be screening tools. I think ultimately, if we had the ability to have more geriatricians, we would be then referring people to get a comprehensive geriatric assessment, but we can't do that. So um, I would say that patient-facing metrics, especially the freed phenotypic frailty, are going to be more responsive to change. So if you're really trying to see and you're going to know what you're changing, right? It's going to be things that we conceptualize. We can really see people get stronger. We can see people walk faster. So I think that if you're trying to intervene in a kind of a smaller cohort, I would say that those are going to be cleaner and have more, probably have more responsiveness, I guess is the easiest way to say that. From a clinical standpoint, I think they also might be easier and help kind of have the patient have buy-in as well so they can see that they're walking slower and you can talk about these things, whereas like if you're trying to introduce to a patient, I see that you're frail from these morbidities and from the medical record, I don't know that there's going to be a lot of buy-in. So I think of VA frailty indices being more important for large cohort studies, really trying to understand outcomes, and I do think that they can be integrated into these operational like decision making tools. And so I don't think it's going to have the same buy-in, but it might be really helpful for a primary care provider to be like, oh, my patient is frail. Here are a couple of things that are kind of red. Let me make sure that I address X, Y, and Z and get these kind of referrals going. So I think, and I worry about frailty indices and their responsiveness. They require, generally they're done with this, 3-year look back. You look at your time point, look backwards for these codes. And so they do change over time because you just move the window forward by every time interval. But they're fraught with how frequently people access care for not outside of the VA or even within the VA. If people get care outside of your healthcare system, you're going to be missing deficits as well. So I think they're great. I'd say that patient-facing tools are going to be more powerful in clinic, I think, whereas these kind of frailty indices that are embedded in the EHR are going to be really important for population healthcare management and research.
Great, that was helpful. Thank you. Other questions?
I have a question. This is Brian Diekman. So I have a basic science background. I've never treated a patient. And I appreciate how you framed things. It was really helpful for me. One thing, I was at a conference where Adam Croft spoke last week and kind of raised the idea that maybe we need to be treating RA patients a little bit differently or stronger to get kind of biological remission as opposed to just kind of surface level clinical remission where if the drugs were stopped, they might come back. And I was wondering if your frailty outcomes might actually be helpful for that concept where you could actually evaluate the quality of different RA treatments or how aggressive to be, or by how many kind of went on to show frailty symptoms. But then
Yeah.
I know you also mentioned that some of the frailty type measures might be caused by some of the treatment. So I'm just wondering how you kind of balance that, of if really the goal is to get these patients to not only have be in remission for RA, but also to avoid something like frailty.
Yeah. I feel like I might answer your question, but there's a couple other things that I'm thinking of when you speak to that. So one thing that is disheartening to me is talking to Connie Wayand, who is very of the opinion that like once you diagnose RA, the cat's out of the bag. These people are prematurely aged, their immune system is exhausted, and their mitochondria are completely dysfunctional. So best of luck. So there's that. I hope that's not the truth, but that's one paradigm of thinking of things. One other thing that came to mind as you were speaking is this idea that we probably could do better in understanding our treatments if we did within studies either go back and control for frailty, because we have these, ageist studies. They don't enroll older participants, and so we actually don't know how these drugs perform in older individuals. So really thinking about addressing ageism and then evaluating frailty as we try and understand outcomes of our drugs, it will be important. But then trying to actually answer your question as to whether frailty could be a surrogate or maybe even a better outcome of success. Is that? I think, I think, yes, we as rheumatologists, when we're treating patients, are all focused on function. And so I do think we're all focused on some aspect of frailty. I think that it's just a longer pathway towards that outcome. And so we're going to, obsess about joint counts and some probably, biomarkers, but I do think it would be a wonderful outcome to think about. And I think we do think about it in our clinical care. That was two different answers and like an attempt at answering your question.
Yeah, no, that's great. Thank you.
Yeah, and I kind of had a related question to Brian. We do have so many choices now for treating RA. In older adults with RA, when we're concerned about frailty, is there a better biological choice? For example, anti-IL-6, which, IL-6 we know goes up with age. It's the gerocytokine. Is there
Yeah.
any evidence that maybe there are specific biologics or other therapies we use for RA that might be more applicable to this
Yeah.
patient population?
I think that's an excellent question, and that's something we need to address in our trials. We need to have people who are older be a part of our trials. IL-6, I think, is very interesting, right? Because it also is important. There's a delicate balance of IL-6 within muscle. You exercise, IL-6 goes up, muscle-related IL-6. And so I don't know. I don't know the answer. There's a small study that showed that IL-6 treatment was associated with improvements of muscle mass in RA. But I agree. I think there might be better ways of thinking about how to treat our patients and perhaps safer methods of treating our patients. Clinically, I see that IL-6 has a role in some people, but it's not the best. Doesn't do a ton of work in all my patients. And then there's always that risk of, perforation, intestinal perforation, which of course, another age-related consequence. I think the biggest thing that I would emphasize, and the data isn't necessarily there yet, but just we need to not lean on steroids. We need to not be afraid of using biologics when we think that steroids might be safer, because they're not.
And along the lines of energy metabolism, metformin has all these positive effects on energy metabolism. And, they've been trying to do some studies with metformin and older adults and, with frailty as an outcome. But I'm wondering, in our patients with RA, if that would be a really good group to study the potential benefits of metformin
Yeah,
with frailty as an outcome, because they're going to be much more susceptible to frailty than just, a general population of older adults.
I agree. Yeah, there's a lot that we're going to take from geroscience and some of these like SASP factors, these other kind of different ways of getting rid of our senolytic cells, or senolytics to get rid of our cells that are senescent, will be really interesting in our prematurely aged patients. So more to come.
Other questions? I'll ask one more if not. And this is not specific to frailty, but I'd like to hear more about how your pilot has been, in particular, how your patient group has responded to the virtual format of your program.
Yeah, so they just completed the 6th week. We have their virtual 7-week assessments. It's in a data set that I haven't looked at yet. I just got that yesterday, and so they're going to come in for their 12-week assessment in the next 6 weeks. I would say that there was at the end when we were adding all these things together, because we did try and like help people understand how to integrate different exercises into a day. People were like, "This is hard," like there's a lot of different movements I need to integrate. And so we're considering even having like expanding it to 8 weeks, having an embedded practice session because it was a lot really quickly. Yeah, there's kind of benefits to that and downsides to that as well. But this of course is just like a group of people who are excited about it. These are people who are already a part of my other cohort. 2 of the 4 are my patients. So like, I think they're going to be, they're different than everyone else. There was definitely someone who was like, I'm kind of not into this. And everyone was like really trying to help her, which was very sweet. But we'll see. I'm excited to see what they have to say. I have one patient who came in for clinical care. He's like, I have so many notes. I have so many notes for you, in my journal. I'm going to give this to you later. Yep. We'll get their feedback.
Yeah. It's just interesting because it's, as you know, the VA is sort of a champion of virtual group exercise, and it's so great for, spreading programs and making it accessible, but there's challenges to virtual group stuff. So exercise in particular. So I look forward to hearing how that goes for you.
We'll see if it's too pragmatic. That's my goal, is to be, pragmatic and try and get people to do this on their own. And I might be off in my own world thinking that I'm going to be successful, but we'll see. Yeah.
Great. Cool. All right. Well, thank you again. This was really wonderful. We appreciate your time and allowing us to learn from you.
Thank you for the invitation. It was a pleasure. Have a great one, everyone.
Bye, everyone.